Glucose is the main physiological secretagogue of insulin from pancreatic beta cells. When blood glucose levels rise after a meal, the glucose is transported into beta cells by the GLUT2 protein and rapidly converted into ATP. High intracellular ATP levels close ATP-dependent potassium channels in the plasma membrane and depolarize the beta cells, resulting in vesicle fusion and increased insulin secretion. Sulfonylureas are a frequently used class of drugs in the treatment of type 2 diabetes. Sulfonylureas exert their effect by binding to the SIR1 subunit of potassium channels on the surface of pancreatic beta cells, thereby closing the channels and stimulating insulin secretion. However, this release of insulin is independent of blood glucose levels, and there is a serious risk of hyperinsulinemia and hypoglycemia. GLP-1 receptor agonists bind to beta cells and stimulate the secretion of insulin only when glucose concentrations exceed basal levels. GLP-1 acts by sensitizing potassium channels to ATP and promoting mitochondrial ATP production. This makes it more likely for the cell to close its potassium channels and release insulin in the presence of glucose. However, GLP-1 cannot sufficiently inhibit potassium channels without glucose. Studies have shown that GLP-1 receptor agonists do not induce hypoglycemia even in fasting subjects. The majority of hypoglycemic episodes in patients treated with GLP-1 receptor agonists occur with concomitant administration of sulfonylureas. Sulfonylureas may induce insulin secretion independent of blood glucose levels, overriding the glucose-dependent activity of GLP-1 receptor agonists.